Thank you very much to to be invited for such a complicated talk following yet another complicated talk. So I changed the title a little bit to providers and caregivers as well as shock survivors as I was preparing this talk moving forward. These are my disclosures which are not relevant to this talk. So I wanted to explore the long-term outcomes of patients and their caregivers that survive cardiogenic shock and really think about some common post-discharge comorbidities that are experienced by this patient population as well as the caregivers and us as the team that provides care for these patients, and propose a potential strategy to address the complex needs of these patients. So how do we measure success? When we're looking after these patients, is success discharge from the ICU, sending them back to their hospital, repatriating them back? Is it putting them to the ward, or is success really discharged to home? And really, what does that mean to these patients? And what matters? Is it quantity versus quality of life? So there's those elements, but then what about us as caregivers? What does success look like for us? And also, what is the impact of just not us as caregivers, but also patients' families, their children, their parents, and then what is happening to the healthcare team? So if we look at this review that was actually published just recently in New England by Margaret Herridge, who really wanted to think about what we know about survival and the long term. So Margaret is actually from my institution, and she's been really at the forefront of looking at critical illness and management of these patients, actually looking at how patients recover. And what we have is we have critical illness really described as this traumatic event for the patient, but not just the patient alone, but also the family. And if we look at what's shown here illustrated is really you have the continuum of care, the construct at the top where you're really actively looking after the patient. You have to look after the family as well, and there's the elements to the care team. And when the long-term consequences on the patient are really the physical sequelae, which is shown here at the bottom. We have not only what happens with ICU neuropathy, delirium, and everything else that patient's going through, but then the mood disorders that is actually being developed over time, and also the other things that happen when patients are moving out of the ICU. What does transition look like from their critical illness to then potentially going into home, the financial distress that they're going through, as well as things that we don't think about when we're looking after these patients, but even things like, are they able to go to work, or even their delayed return to work? If we look at the caregiver, meaning the caregiver and the family, there's actually some interesting data that's actually been shown that even with the high degree of caregiver burnout and stress that these families experience, there's actually an increase in their 4-year mortality that's been shown. And the caregiver and essentially the family will have symptoms of anxiety, depression, PTSD, and even panic. They will have prolonged complicated grief if the patients, they don't necessarily have to die, but just the grief of what they've gone through. They'll have thoughts of suicide. Some of them will turn to substance abuse. And this is an incredible financial stress on many, many families, with having families having to leave and have an absence from work, or even their own delayed response, being able to, their delayed return to work. Now, what about us as the ICU folks that are looking after these patients, the nurses, the trainees, even the allied health professionals? This is a team that's looking after these patients. There's a lot of times when there's moral distress amongst our nurses who are looking after these patients with the high mortality that we are experiencing in essence in looking after these patients. There is also a perception of inappropriate care, in that many will feel that with the protracted patient suffering, are we doing the right thing? And so there is a huge burden of burnout, anxiety, exhaustion. There is absenteeism from work, and some of our colleagues will actually change their jobs and leave the critical ICU scenario. They will also have depression and other mood disorders. Some of them will actually really suffer from substance abuse and will have issues within their own marriages, parenting, and even their social relationships will be at risk. So things that we don't think about in the day-to-day work that we're doing. So the concept of this post-intensive care syndrome is really building, and really is affecting, which I didn't realize how prevalent this was, but it's affecting about 80% of patients and their families and caregivers. And they will have a constellation of symptoms, which I've kind of illustrated here, the survivor and the family, and there's a cross-pollination of this. So the survivor will have the physical health and the issues with swallowing, neuromuscular dysfunction, mobility issues, not even being able to do their own ADLs, cognition being affected. But then there's the social construct and the social determinants of health that affects both the family and the survivor. So what does survival look like? It's not necessarily recovery. We have lack of routine follow-up moving forward. Discharge planning from the ICU can be actually difficult because what we're relying is on primary care physicians, which not necessarily are able to deal with this. And there's a lack of awareness of the post-ICU care syndrome. And what do we know about survival? If we look at the recovery program, it's actually pretty terrible. I'm speeding up because I only have 1 minute left. Patients who spend more than 7 days in the ICU actually will have a length of stay of approximately 20 days. 60% of these patients are unable to walk after 7 days of being in the ICU. And really the biggest determinant of risk is age and length of stay, not the admitting diagnosis, which is interesting. And 1 year after ICU discharge, you have 40% of patients over the age of 60 with more than 2 weeks spent in an ICU are unable to dress themselves or climb stairs independently. And then there's this whole slew of readmission rates, PTSD, depression, etc. This also reflects what's happening in our cardiac patients as well. So long-term morbidity and mortality is very high. If you look at patients that are admitted to an ICU with an acute diagnosis of AMI, and here out-of-hospital cardiac arrest was excluded, you see that the 1 year mortality is 41%, but at 10 years it's 70%. And morbidity is in the 50% range is what we're looking at. Mental health is a huge issue. In this study, what we have is 27% with mood and anxiety disorders, 12% with mental disorders, and even schizophrenia and substance abuse. Our own experience is not different. Looking at my own data at our own institution, we see our own 5-year mortality. You see the initial drop, but this mortality continues so that by 5 years we have 63% mortality. And one of the major issues, which is maybe not easy to see, is that there's no follow-up when these patients get discharged. And what we've done is we've looked at what that looks like, and it turns out that about half of our patients do not have follow-up in a heart function clinic. And we look at patients with cardiogenic shock with known heart function follow-up. We see that we have, even in that population, only 6% get referred for advanced heart failure treatment or after the repatriated or discharge, but survival is better if you have follow-up in a heart function clinic. Where do we go from here? Really, the whole idea is developing these CICU recovery clinics. There's a whole process around that has been published, and it's really something to really think about, but it's a very complex kind of system of care that you're providing these patients. And what's proposed is that initial visit is a really lengthy thing, not only just check-in, but thinking about what happens to these patients in the ICU. And this is something that a few centers are actually taking on, including ours as well, to see about helping through the recovery in the post-ICU cardiac patients. So in summary, patients do not stop having issues after they've been discharged from the ICU. There's this really important concept of a post-intensive care syndrome. It is real. Survival is not necessarily recovery. And what happens to these patients once they leave your ICU, it's really important, because what you really need to think about is how to provide good continued care in a heart function clinic setting. It does have been shown to have improved outcomes. And really, what's needed are more of these recovery clinics in the community. It is a data-free zone, but it's a really important intervention. And we need champions. Thank you very much. I'm happy to take any questions.
Thank you so
Thank
you so much, Phyllis. That was great. So this is open to questions, comments from the audience and the panelists, please. Yeah.
So, Phyllis, that was really, really amazing. As I sit and think about it, it's incredible. We work so hard in the ICU, and then the patients are basically just dropped. We assume, clearly and correctly, that somebody else will just take care of them, or that they come back from rehab. But certainly in transplant, those first few precious patients we watch because they monitor us. But it is fascinating to think how many patients don't have follow-up. That's really
It's actually, we're doing them a disservice. So I think as a community, we have to think about them throughout their whole continuum of care. We get them through their shock, right? We have a high mortality in the first 2 weeks or so, but then that mortality continues because they don't actually get the care that they need in the long term. When I was asked to do this talk, I thought, why me? But then I actually learned something from it, and it's, no pun intended, it's shocking what I found out. And what we've done as an institution, I think, is a small step in the right direction, and we all need to do it.
Phyllis, it's amazing to see that 40% are dead in a year, and the 40% that are alive still can't bathe themselves. It's enough to make you wonder whether those countries that triage resources may not be onto something, and we should be a little more careful and look at those that we survive that really don't do well.
Yeah, the statistics are astonishing. They're just astonishing. And it's not just the physical ramifications of being in shock and being in an ICU, it's also the mental anguish, the anxiety, the PTSD that we, as healthcare providers, we're used to dealing with high intensity, but we're not really all touchy-feely. But this is really what happens. In my own heart function clinic, I think I spend a lot of time around depression, mental disorders, mood disorders that if you get an inkling, I actually explore it, and it's really helped my patients survive even their acute heart failure decompensations in hospital.
Yes. Phyllis, thank you so much. In your opinion, who should be running this clinic? There's a primary care physician shortage. I'm a general cardiologist. The last time I prescribed an SSRI, I was an intern in my primary clinic.
Yeah, no, it's a great question. It's like who should be prescribing Ozempic? It's kind of that kind of thing, right? I think what you need is a multidisciplinary approach like we do in everything. We need a champion to take this on. So we actually have our CICU colleagues that are doing this. We have 2 CICUs, our CICU director, as well as a new staff who's really interested in this. So we have 2 people that are taking this on, but we also have a psychiatrist who has a particular interest in cardiac patients that we've been referring to. And it's really having that multidisciplinary approach. I wouldn't feel comfortable, prescribing an SSRI actually either, but you will build that comfort level, and it's the multidisciplinarity.
Excellent. Jonathan, please.
Hey, great talk. As somebody who moved from the bedside to the coordinator position and got to see the full arc of these patients' course, I think burnout really comes from not seeing some of the wins. I think it's so important to celebrate the wins in our programs, and also just to be honest with the staff about our outcomes, because you only see things as a nurse usually 3 days at a time, even as a attending 7 days at a time. These patients are not in the ICU for just 7 days at a time often. There has to be some way, I think, for us to really promote these outcomes and talk honestly and openly about how these patients do to fight some of the cynicism. Second thing was we involve palliative care in all of our shock activations, and they do a really good job of handling a lot of the psych meds, the antidepressants, the antipsychotics, and I think it does make a difference. A lot of the things that you talked about as far as not being able to bathe at 6 months are very nursing driven, and I think getting nursing on board with like the ABCDF bundle that is proven again and again to affect these outcomes, fighting that cynicism with nursing is huge probably in promoting long-term outcomes in these folks.
Thank you for your comments. I would have to say, though, because of that, still we haven't moved the needle on mortality. It's still the big issue is that the majority of patients are still dying, or 50%. So we're dealing with that. And I think from a nursing perspective, I know that I've had many scenarios where nurses will come up to me and say, why are we still torturing this patient? So there's that one concept. And it's not just the nursing that feel this. I think we as physicians sometimes are at a loss what to do and how long are we prolonging care. That's the one side of it. And we have patients actually in our own institution who are so grateful and start walking through the unit just to say thank you. It's still not enough, but we need to do more and we need to do it better. But thank you for your comments. I much appreciate it.
Thank you. We are out of time. Very briefly, please.
My name is Lauren. I am an APP down the street at Texas Children's in the Adult Congenital Heart Unit. We have a lot of patients, that have had ongoing lifetime issues, and of course, we deal with a lot of shock. We have brought on a dedicated psychiatrist that sees our patients on a regular basis. it has shown to improve our patient outcomes and to improve our situations with follow-ups. And it just seems like a great idea to have if there's sources that can be allocated for that.
Yeah, no, it's a great point. The problem is not in when we're looking after the same patients. It's the patients that leave our ICUs and get repatriated back to a different hospital, a different ICU, and they're lost. The ones that stay in our own institutions, we're probably doing a not so bad a job. It's the ones that are just lost. And it's a huge majority, at least at our institution, 75% of our shock gets repatriated back or gets, and so you're left with this poor GP who doesn't even understand what happened necessarily to their ICU stay, and then dealing with the aftermath. So what we're doing at our own institutions is fine. It's how do we reach in and bring in the ones that are lost.
Thank you. Thank you so much, Phyllis. So